Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answers. I'm your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. To grow this community of information and action, I hope you give us a 5-star review. Come visit me on hightruths.com to learn more about the show or download a free prescription for naloxone. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Today's episode is sponsored by Families Against Fentanyl. FAF is an organization set on attacking the supply chain of deadly illicit fentanyl. To learn more, visit familiesagainstfentanyl.org and sign their petition to declare illicit fentanyl a weapon of mass destruction. Hello again, High Truth listeners. Get ready for a methamphetamine conversation. I'm your host, Dr. Ronit Lev. Methamphetamine is a stimulant drug that starred in the Breaking Bad television series. Methamphetamine produces a high, keeps you awake, but also raises heart rate and blood pressure. German pilots used meth in World War II to stay awake. ISIS terrorists used Captagon, the Middle East version of meth, for their activities. And recently, Hamas terrorists used Captagon to enhance their brutal attacks on October 7th. In the emergency department, I treat patients with violent and scary reactions to methamphetamine, combative agitation. And these violent reactions are a danger to the user, but also to the emergency staff. On a daily basis, I treat various medical complications of methamphetamine, such as heart failure, mental health emergencies, and various infections. The homeless population are especially hit with meth. And yet, we do not have medical treatment and resources for people with methamphetamine use disorder as we do for opiate use disorder. Each patient who has an opiate use disorder, we rush to treat with buprenorphine and referred with a warm handoff to a clinic. But what about patients with the methamphetamine use disorder or cannabis use disorder? What do they get? Very little. When I study the overdose mortality in California, I see that 50% of deaths involve methamphetamine and 50% fentanyl. And yet there's a huge overlap of the two drugs. And when I treat patients, I notice that many patients who overdose from fentanyl was not their drug of choice. They didn't intend to do that. I can send them home with a prescription with naloxone, but buprenorphine will not be relevant to them. The data from the medical examiner office and patients in the emergency department tell me that in California, the emphasis cannot be just on buprenorphine treatment to solve the fentanyl crisis. If in half the patients, the drug of choice is methamphetamines, then we need equal emphasis on treating methamphetamine addiction. But there is no FDA-approved medication to treat methamphetamine use disorder. Contingency management, which is behavioral treatment, resulted in 92% negative drug screens and 28,000 drug screens obtained in 2 separate studies from the Veterans Administration, the VA. That's pretty good results. So why isn't everyone and every patient who comes to the emergency department with a methamphetamine-related problem get referred for contingency management? To learn more about contingency management for methamphetamine use disorder, I reached out to Dr. Thomas Freese. Dr. Thomas Freese is a clinical psychologist. He's currently co-director of the UCLA Integrated Substance Abuse Program, ISAP, and he is co-director of the Pacific Southwest Addiction Technology Transfer Center, funded by SAMHSA. To learn more about Dr. Thomas Freese, check out the High Truth show notes. Dr. Thomas Freese, welcome to High Truths.
Thank you very much. Happy to be here today.
I'm excited to be here. I met you as we did a panel together with the National Overdose Prevention Leadership Summit. We talked about contingency management for methamphetamine, and it was just so short. I said, I need to have a conversation with you more in depth and learn more. So I'm very excited for that opportunity.
Great. Me too. I'm looking forward to delving in.
All right, so let's start as I usually do, but just getting to know you a little bit. You're a clinical psychologist, and somehow you came to be a professional trainer and teacher for others in addiction specialty. So tell me how that happened and why, out of all things, you chose addiction.
Yeah, thanks. Addiction for me was sort of an accidental specialty. I started my training, and while I was in graduate school, started working with homeless and runaway adolescents. Started out doing research, and as I gained more clinical skills, started doing clinical work with them as well. And given that population, I realized very quickly that I wasn't going to be able to help them at all unless I knew something about the substances that they were using. And so I gradually developed an expertise in substance use as I was working clinically with that population. And by the time I left Children's Hospital Los Angeles, 8 years later, I had started the substance use treatment program there at the Division of Adolescent Medicine. I moved from that role into a research trial where I was directing a research trial looking at behavioral interventions for methamphetamine users. And contingency management happened to be one of those interventions, but spent several years in that research environment, actively conducting research and learning kind of the connection points between research and clinical work. And then was given the opportunity to start the training department at UCLA Integrated Substance Abuse Programs. And our mission there was really to bring the best of science related to addiction to providers in a way that could shorten the time it takes for research findings to get into real world clinical practices. And that's what I've been doing for the last 20 years or so.
Right. So you're teaching, but do you have contact with clinicians and feedback to find out what's happening on the ground?
Always, yeah. Our primary audience for our teaching are clinicians who are active in the field. So while we're one step away from the clients, all of our education is really about sort of what are you doing in the context of your clinical work, and how can we shape that to hopefully improve the outcomes that you're getting based on what we know from research.
Interesting. Our we have a common beginning that at Children's Hospital of Los Angeles
Really?
back in the day when I was first started medical school. I thought I wanted to be a pediatrician, so I would spend the summers at Children's Hospital in LA in the emergency department, and that's when I learned about the specialty of emergency medicine because I've never heard of that. And they said, "Hey, you may want to be an ER doctor," and I thought, "Oh, I didn't know that exists," and it fits. So I owe
Amazing.
a lot of thanks to Children's Hospital of LA for that.
I love those small world connections.
Um, so methamphetamine, it's a stimulant that does it can I see as an emergency department crazy behaviors.
Yeah.
But tell us what can you teach us as a teacher about methamphetamine and methamphetamine use disorder?
It's a big question. We could spend the next 3 or 4 hours answering that question. But in summary, methamphetamine is a powerfully reinforcing psychostimulant. So people use it to get that up feeling, and it feels in initial use, it feels like excitement, it feels like pleasure. It sort of gives you energy for days. You don't need to sleep, and you kind of lose your appetite. So you don't need to eat as much either. So people will sometimes use it in association with weight loss. But as you continue to use, excitement begins to feel like agitation after a while, and it becomes uncomfortable. And we start seeing some of the negative effects of kind of overstimulation, weight loss to the point of anorexia, severe anxiety, in withdrawal, severe depression, and suicidal ideation very often. And we see what you often see in the emergency departments, which is psychotic kind of processing. We overstimulate the brain, therefore, the brain begins to experience things that may not be coming from external stimuli. One other thing that I want to note about methamphetamine is that by itself, it produces overdose at fairly high rates. And we're seeing an increase in overdose related to methamphetamine across the country. But alarmingly, there's also more and more fentanyl mixed into the drug supply associated with methamphetamine. And so as we're looking at overdose rates, and we know from the news that fentanyl is the big the underlying cause associated with many of those overdoses. But when you look a little deeper into the data, many of those fentanyl deaths are also stimulant associated as well with methamphetamine. And in the Eastern Seaboard, although less overall, sometimes cocaine mixed in that as well.
Yeah.
So we're never going to address the overdose problem if we don't address the methamphetamine problem.
Oh my gosh, I love you. That's exactly right. Because when I looked at, we produce a report card every year in San Diego, and the number of fentanyl deaths was about 815. The number of methamphetamine deaths was 805.
Right.
And the overlap. And what I see in the emergency department, we're like trying to buprenorphine our way out of the crisis. And I see people who overdose on fentanyl, but their drug of choice is not always fentanyl. So that tells me we can't buprenorphine our way out. We're not going to naloxone our way out.
Right.
But
it's a good step in the right direction, and we need those tools for people for whom primary opioid use is the issue that's putting them at risk. But it's not the only answer to this issue, and we won't solve the problem by, as you said, buprenorphine our way out.
And yet, especially in the homeless population, methamphetamine seems to be a big drug. And the kind of gap that I see is that we see patients in the emergency department, if they have an opiate use disorder, then, oh, good, we're something we could do. We have a tool, we have a follow-up. But if they have methamphetamine use disorder, then we don't have anything. So that's the, and you know what, the type of patients that I see, we have the acute psychosis where they just took the drug and they're way high or psychotic or a bad trip and agitated. We see people who are crashing from meth, and withdrawal from meth is interesting. It actually doesn't feel so bad like alcohol withdrawal or opiate withdrawal. They just crash. It's like, hello, this is Dr. Lev, can I help you today? And they're just like, no, I'm just tired. I just didn't sleep. And they're out. It's hard to wake them up. And they don't even understand that that's the meth crashing. We see the tweaking, people's behavior have, and also the terrible medical consequences of heart disease, of infections. If I see a young person under the age of 50 who has a pacemaker or AICD, chances are that happened from methamphetamine.
I think that, the kinds of things that you see in the ER, they're all treatable. If they're psychotic, the research would say that we want to calm them down, give them antipsychotic meds if needed to calm the system down. While they're withdrawing, you're right. Generally, by itself, it's not medically dangerous. They need a place to sleep for 2 or 3 days to let the drugs come out of their body. And then they wake up feeling probably somewhat depressed, but fairly normal other than that. So a lot of times people don't think, because they can go through that cycle of just kind of withdrawing, sleeping for a few days, and then wake up and feel okay, they don't necessarily think they're addicted like people get addicted to other drugs. But what we know is that deep in the pleasure centers of the brain and elsewhere in the brain, we're changing the way that the brain functions. And in some ways, the way that the brain is structured so that it functions differently on the back end from methamphetamine than it did before people started using methamphetamine. And that's where the seed of addiction happens. And that's where that compulsive return back to methamphetamine use happens. And so we have to figure out a way to counteract what we've done to the pleasure systems of the brain in order to make other things pleasurable, life itself rewarding, so that we can help the person move back toward a normal, better functioning life.
And that's a great explanation. Isn't it true that it's the same whether it was cocaine or cannabis or alcohol or any drug, really?
Yeah, all drugs work in the pleasure center of the brain. And so they're all changing those reward pathways in really significant ways. Each of those substances, though, operate in somewhat different ways. And so the neurochemistry involved and the way that we go about intervening with people may be somewhat different. Behavioral interventions work really well if we can get someone engaged in treatment with cannabis use disorder. They work really well with alcohol use disorder, often in conjunction with other medicines to help both through the withdrawal period, but also on an ongoing basis. With opioids, the front line is medicines. Get them stabilized on those medicines, stabilize the brain neurochemistry, and then add in those other behavioral treatments as appropriate. With methamphetamine, those behavioral treatments are less successful. It's harder to engage people in care. It's harder for them to see that they need to continue to engage in care. And the substances, methamphetamine and cocaine, actually, all stimulants, the substances are so powerfully reinforcing in and of themselves. It just the behavioral treatments that we have don't work nearly as well, with the exception of what we're here to talk about today, which is contingency management, and that does seem to change the equation a little bit in terms of treatment.
Yeah, I've seen slides and I've given presentations on methamphetamine, and two slides kind of stand up. One is the dopamine surge that you get from methamphetamine. Like right now, you and I are talking, we have about 40 units of dopamine as just to kind of sustain us. A great day in our lives, winning the lottery is like 100. And for methamphetamine, it's 1,000, like more than heroin or cannabis or any other drug.
Yeah.
And so I see that like that's neurochemically different. And the other part is when they've done the PET scans of the brain for specifically methamphetamine, and you see these pictures of holes in the brain, and I thought that was pretty remarkable.
Yeah, that powerfully reinforcing effect of stimulants, and cocaine goes up to about 500, and you're right, methamphetamine goes up over 1,000, sometimes 13 or even 1,500 units inside the brain. There's nothing that equals that kind of pleasurable surge, which sounds really enticing, but again, you don't get that for very long before the brain starts adapting to that. And what we see is a downregulation in the dopamine system that causes real shifts in functioning, not only in the pleasurable sensations, but also in cognitive functioning as well. Now, those pictures that you talked about with holes in the brain, I think what you're talking about are actually functional MRI scans that they did of the brain, and they model the brain in 3D, and they show where the brain is working well and where the brain isn't. Those images are often very misinterpreted because it looks like you've got a big structural hole right in the middle of the brain. And we know if we remove brain tissue, it doesn't regrow. And therefore, that's just a permanent loss that is gone forever. That is not what those pictures are showing. Those pictures are showing a functional deficit. And so when they model what's working and what's not, we see a big gap in functioning in the frontal cortex and in the dopamine centers. And that's just a reduction in the amount of dopamine that's available in those sites, a reduction in the way that those areas of the brain functions.
Yeah.
In that, there's a lot of hope because in that, we know that over time, that functioning begins to return. And so on those scans, if we did the same model, those holes would shrink and those holes would go back to looking much more like a normal brain as the person gets longer and longer time away from the drug itself. I interrupted your question.
No, I think that's great. That's exactly what I was going to say, is that holes, those functional holes, and I thank you for that correction because the pictures are pretty impressive.
They are.
But those functional holes in the brain, and they make a good visual, but they can be fixed, and there's hope. And I've seen the same kind of images with the heart, and the people who have methamphetamine is toxic to heart tissue.
Yeah.
Cardiomyopathy, heroin and fentanyl actually isn't. So, and if they did studies looking at ejection fraction, how strong the heart can squeeze, with people who have cardiomyopathy and heart failure from methamphetamine, and if they quit, you can get it back. So there is hope. And
a lot of what causes overdoses actually is certainly the direct result of the drug, but we also wear out the system when we overstimulate it so dramatically along the way. And so a lot of what we see are heart attacks and strokes and seizures that are actually the primary result in death, resulting from the drug use, certainly, but things that happen, as we kind of wear out the body in aging, we see those even in very young people because they've overworked those systems so dramatically.
Yeah, exactly. People who die from methamphetamine die a respiratory death. They're not breathing. And people who die from methamphetamine without fentanyl in it are dying from a cardiac death.
Yeah.
Yeah, and here in Southern California, that's a primary problem equal to our fentanyl issue. We did a study of urine samples from the emergency department, and 76% of the drug screens that we obtained were positive for meth. So crazy number, but there's hope. And that's what you're going to teach us about also, treatments and hope for methamphetamine. And during our summit, we talked about contingency management. So what is that? What is contingency management?
Great question. Contingency management is a behavioral intervention, purely behavioral intervention, that's designed to reshape the reinforcers that the person experiences in their world. Now, concretely, what does that mean? It means that what we do is we monitor some specific behavior. And in the case of the studies that I've run, we're looking exactly what you looked at in the emergency department, which is urine drug testing. And if they test negative for stimulants, for methamphetamine, they get a concrete reinforcer. And what we give them is actually money in the form of a gift card. Now, people often react to this in really significant ways and say, we can't be paying people not to use. And while we're using a really powerful reinforcer, and that is money, the goal is not to pay them not to use, but to actually reward them in a really concrete neurologic way for doing the thing that moves them in a positive direction. And in doing that systematically, if we do it really, really well, what we've shown is that it reduces very, very quickly the amount of methamphetamine that people use, and it keeps them away from methamphetamine longer than many of the behavioral interventions that we have. There are a couple of big studies that have been done that are studies of studies, because this has been being researched for over 30 years. So they took a lot of those studies and they put them together. And they said the single best thing we can do for someone who uses methamphetamine or cocaine is use contingency management in their treatment. And in fact, when we add other treatments onto that, other behavioral treatments, we get a small additional effect in those research studies. But it's kind of vague and non-specific. In other words, most of the impact that we get is from the CM itself, and then we can use other behavioral treatments to support that and probably get some additional benefit for some people in addition to the contingency management.
And I saw one headlight, California paying, drug addicts not to use, right?
Well, technically it's true. It really isn't the core of the intervention. What we're doing is we're giving them a new reinforcement structure. And, it doesn't take a lot in order to get someone to make that change, because it's the connection between demonstrating the behavior and the reinforcer, as we know from a purely behavioral perspective, that begins to make that reinforcer. So we actually start with a fairly small amount in the California project. And over time, the value, as they get longer time absent, the value increases to make it more and more reinforcing as they get more time away from the drug, to hopefully hold them and continue them through that process. But it really is about making life itself reinforcing. And then over time, life does become reinforcing as more good things start to happen to the person as they move away from their addiction.
So, Tom, tell us about this California project.
Yeah. The Department of Healthcare Services at the state of California received permission through the Center for Medicaid and Medicare Services to conduct a large pilot of contingency management statewide, funded in part through Medicaid billing. Medi-Cal is what we call it here in California. And so we can bill Medi-Cal specifically for the clinical intervention part of the services associated with this particular intervention. And then the state of California has worked out other ways to pay specifically for the incentives, which are not billable directly to Medi-Cal. And so we're looking at a project to in real world settings, when we're fully launched, of having over 160 sites across the state of California in 24 different counties participating and offering this particular service to their clients.
So this is not happening yet?
We're in process. We've launched currently in 14 counties, San Diego County being one of them, my home county, Los Angeles, being another of those counties. There are currently active services going on in each of those counties. We're continuing to grow both the sites in each of those counties, as well as the number of counties as they take care of administrative issues that are necessary in order to come on board.
Right. And how's that going? What feedback are you getting?
It's going really well. There was some nervousness about whether this was going to work, particularly among some of the treatment providers. And to a person, we found that the providers like it. And the providers like it because it seems to be working overall. Clients are coming in, they're able to test negative, they get the reinforcers. They use the reinforcers for amazing and health promoting things, and life promoting things like buying a new shirt to be able to go to a job interview. Or one provider reported that they had a client come in and they were in tears, and they said for the first time in 5 years, they're not stealing their children's Christmas gifts, but they're actually able to buy their children's Christmas gifts. There's story after story after story of people seeing the benefit of not using drugs and being able to apply that concretely to their lives. So providers really like it, and we're getting pretty good outcome rates, better than what we're seeing in the research so far in terms of the number of negative samples that we're getting as people are participating in the program.
So contingency management is happening now in California, but is it just a small pilot or a lot of patients?
Yeah, the number of patients are growing rapidly. We looked at the data a couple of weeks ago, and in the 14 counties that are currently actively enrolling clients, we have about 55 sites that have enrolled people in their treatment, totaling just over 1,000 people. And we have conducted over 13,000 urine drug tests at this point. And if you include unexcused absences and positive tests, assuming that if they didn't come, they might have actually used, we're showing about a 75% negative urine drug rate at this point. So the numbers are really good. In the research trials, by the way, the average was about 50% negatives, and the intervention still works. So that we're getting those kinds of numbers shows that people are really interested and are taking use of it. The other thing that this pilot is going to show is we can do anything in a research context, right? We control everything. We make sure that all the elements are in place so that it works exactly perfectly. But can we do this in real world clinical settings, but with the kind of rigor that it takes in a behavioral intervention to do it right? And the answer so far seems to be, as our program is growing, that we can.
So tell me what kind of, how do you sign up a patient? What do they get for signing up? What do they get each time? What are these incentives?
Well, first of all, to bring a site on board, it's pretty extensive for the site in terms of the training that's required. The county will identify a site. This site is going to be able to provide this, and they've demonstrated they have a large enough pool of people who are using methamphetamine or other stimulants that they make sense to run this intervention. They then have to complete a series of 3 different trainings. There's a self-paced training to give them some basic introduction to the concepts, and then a 2-part implementation training that tells them the nuts and bolts and the specifics of how to implement the program. We then do a readiness assessment with the site to make sure that they've got all the systems in place in order to be able to run the program, and that they know how to use the system that we use to track the urine drug tests. And once they do all of that, then they're given the clearance to launch. And basically what happens is a person will come into their program. It's being done in all outpatient settings. And a person will come in and they'll do a regular intake through the program. And if they're identified as having a stimulant use disorder, they're offered the contingency management program as a component of their treatment. Now, someone can go into one of these programs that only receive contingency management, or they can receive contingency management along with all of the other services that are offered through their outpatient program. What the person gets is an effective treatment. And they get the incentives associated with the project. And so they come in and they're introduced to the program. They're given a consent form to understand what it is that they're getting into. And if they agree to sign on, they'll do a urine drug test. And if they test negative, they get a $10 gift card, and they can select from a wide variety. I think we have 18 or 20 different gift cards that they can select from according to what would be most reinforcing to them. Then that's the intervention. They get a feedback session that lasts somewhere in the neighborhood of 15 minutes, and then they either go on to the services and the rest of the program, or they go home. They come in twice a week to do that. And the next time they'll get $10 as well. But the third time they test negative, they'll get $11.50. It goes up by $1.50 for every 2 consecutive negative urine drug screens that they get. So it will build up over time, becoming more and more reinforcing. One of the concerns, though, is what if they have a slip, right? They have a use episode, or they just don't show up one day. In that case, they go back down. They don't get reinforced on that day if they test positive. And the next time they come in and test negative, they're back to $10. But we don't want that to be just to get them started again. But we don't want that to be punishing. And so what we do is the next time they test negative, they bounce back to where they were before and get the next escalation again. And so the amount that they lose from a use episode is actually fairly short and fairly small. And then they get right back on track and continue the good work that they're doing.
So they can make $20-25 a week?
Over time, yeah. But if they get to the end of the program, which is 12, the active program, which is 12 weeks long, their final 2 urine drug tests will be about $27 each. Yeah.
Right.
If they stayed negative the entire time through that.
And this might be a strange question, but is that enough, $10-20 a week, when you can just go to Walmart and steal, almost $1,000 worth of stuff with no punishment?
Sure. Yeah, again, it's not about the dollar amount of the incentives, and it turns out it is enough. There's some research questions that still need to be answered, which is what is the optimal amount of the incentives that should be offered to people. In the research and that where they showed that this was effective, the amount of incentives ranged from about $200 to about $1,100, I believe, was the upper amount in terms of the total amount they could earn if they were abstinent the entire time of the program. California, for lots of reasons, settled on an amount of $599 for the total program. Again, our results so far, while we haven't done the official evaluation, the numbers are looking good that we're getting results similar or better to what we saw in the research.
I have an idea for you.
Sure.
One common denominator with people who have severe methamphetamine disorder is meth mouth, and they have horrible teeth.
Yeah.
And so I've heard, public health say, okay, we just need to fix their teeth. And I thought, no, you need to build that into contingency management. Stay off meth for 6 months and a year, and then, we'll fix your teeth, as an incentive. So it doesn't have to be money. It could be services such as, the dental care.
I love that idea. And there's 2 points I want to make about that.
Yeah.
Use of reinforcers is different than contingency management, right? Contingency management is applying a specific reinforcer to a specific behavior every single time you see it. And it needs to happen with enough frequency that we're able to reinforce and reinforce and reinforce and reinforce and reinforce and reinforce and reinforce. And so if we look at things like, if you stay abstinent from meth for a period of time, you get a reward and a big incentive at the end of that. That use of that incentive and that carrot out there could be a thing that helps them motivate and get all of those reinforcers along the way. in and of itself, it's not contingency management.
Mhm.
It is a reinforcer. It's a positive. It's a gain. We all do things because it feels good, and we want to get some big reward out of it. But we don't want to confuse those two, because programmatically, if you were implementing that, we'd want to make sure that we're reinforcing something that has enough power to actually shape the behavior that we're talking. Now, then reinforcing, sort of getting them to a point and creating a contingency management program specifically to encourage good oral hygiene and access to dentistry and all of that kind of stuff. I could see a program like that being developed. Right now in the California project, we're starting very simply and very concretely with a single behavior, and that is urine drug screen that's negative for stimulants. And the reason for that is it's the first large-scale pilot that's done in real-world settings. There was one in the VA, not quite as large as the one that's here in California, but the VA is, again, kind of a closed system where they have much more control over things. So this is the first one that's being done really in the wild. And we wanted to show, first of all, that it works with all the controls that we're talking about. And then we can start talking about other behaviors that we may be able to reinforce and other ways we may be able to apply this once we have the proof of concept through this plan.
Right. Teeth is one thing. The other thing is housing. I see a big push to find housing for people, and yet that housing becomes, I'll give you an example. We had Alex is a guy who used to come like on a regular basis. We know him. I'd see him out in the parking lot. Hi, Alex. And he was a guy with schizophrenia and terrible methamphetamine use disorder. And he'd come in regularly with psychotic, and we'd treat him, and we try to get him case managements into shelters, and yeah, he was a revolving door. And he finally got into housing. And once he got into housing, guess what happened to him? He died. And he died of fentanyl in the housing project. And that wasn't even his drug. So I was thinking, is this housing helping? I mean, shouldn't there be, I think, priority for housing? It could be used as an incentive also. Like, you could do this contingency management, get that behavior going and that routine going and that reward, and then do things like you said, clothes or dental care or housing, and to have housing that's a drug free, I think is important.
Dr. Lev, I don't know that I fully agree with you.
Okay.
If I lived on the streets, having worked with homeless kids for a long time and done work with the unhoused throughout the course of my career, if I lived on the streets, I would use drugs, period. The streets are much more horrible than anyone thinks. And survival on the streets, people will use methamphetamine so that they don't fall asleep, so that someone doesn't steal their shoes and they wake up barefoot in the cold. Life is really, really horrible. And I think it is criminal that we don't house people, particularly house people with severe mental illness, with severe substance use, et cetera. And I think we need to acknowledge that people with severe mental illness are going to show symptoms of their disease and not punish them if they show symptoms of their disease. In other words, people who use substances are going to use substances. Does that mean we kick them out of their housing? I think that housing people is an intervention for mental health, and housing people is an intervention for substance use disorder. Now, I'm really sorry to hear about the case of Alex, and I've heard that story.
I agree with you, Tom. It's heartbreaking. We're like a third world country.
Yes.
With what we're seeing on the streets, and nobody should be in the streets, period. I guess the problem that I see is, okay, if we just have the housing without something else, an opportunity, and address the addiction, then you just got them housing.
I agree. We need to connect the two. And, supportive housing is really what I think is the magic bullet, as it were, if there were one, which is to make available all of those services to people that you're providing the housing for, and do everything we can to encourage them to make use of those services. I've heard stories like Alex's a lot. I'm going to finish this thought, though, if I could. Go ahead. I've heard stories like Alex's a lot, where, you finally get him into a safe place and he has an outcome that is less than desired. In his case, he died. And what I say about Alex is, how fantastic is it that he died in a place where he lived, where he felt comfortable, where he felt safe, and that he had a fatal condition. The risk of death, the prognosis for his condition is not great given all of the concerns that he has. But at least we gave him the dignity of space, and we gave him the dignity of working with him to try to change the outcome that he was destined for, and maybe ended up with just a bit more respect.
Well, that's a positive spin on that. I think about Alex a lot, and I feel like we failed him as a society because
we did. And in the last moment, while we failed him for a society throughout his whole life, we found a way to give him a little bit of human dignity.
Yeah. And right. I mean, that's true, but in the big picture, it would be nice if we weren't there in the first place. The other thought that I thought of, in getting housing and the push for housing, there at least should be people's choice, like I want to live in drug-free housing, or I want the hope, versus drug. And we don't have that distinction for people who are ready to make a change and people who are not yet ready.
I think that the state of California is working really hard on these housing issues, and there is supportive housing available to people. There's transitional housing as people are coming out of both mental health and substance-related programs. There are more housing opportunities available, but as we know, while we've been neglecting it, that the unhoused crisis has gone through the roof in terms of the number of people who need those services for lots of reasons, but it has remained unaddressed. And so I think we're digging ourselves out of a problem that is monumental, and people are dying as a result of it. I completely agree with you. But I think there's hope on the horizon as we think of new creative solutions to both get people into safe environments and connect those environments to healthcare. And I mean that broadly, both behavioral and physical healthcare, in ways that are both acceptable to people and available to people when they need it. Remember, these people also have been treated really badly by the healthcare system. They come in and they get treated as if they smell, and as if they're disgusting, and as if their problems are their fault. And they probably do smell, and they probably are unwashed. But again, it's probably because they have no other options at that point. And the more we can treat people with respect, the more they're going to be willing to step forward and take advantage of those services. And the more that we create open spaces, the more we're going to be able to see those people and provide those services in the way that they need.
I see that happens when we have tools, right? So now that we have tools for opiate use disorder, that respect and hope happens, right?
Yeah.
And because as somebody in the healthcare field, and looking at my colleagues, we get, you're treating people with disrespect. I'm not, that may be true, but it comes from an inner frustration, like, what am I going to do? But when you have something like, we're in this profession in order to help. When we're giving tools to help, that makes, that's what we came into this profession for. And I think that's where you see that behavior on the health provider end come from.
I don't think we're ever going to have a tool as simple for stimulants as we do for opioids. Those medicines are powerful in terms of reshaping people's lives and making other behavioral interventions and medical interventions possible. Contingency management is a complicated intervention that requires special training. It requires special setup. You have to have money for the incentives. There are lots of barriers to being able to implement contingency management. So figuring out how we link your emergency department with the programs that we're talking about in San Diego County so that they get a direct link if they're a stimulant user out to those programs becomes really critical in shaping the systems in a way that give you hope as a provider and give the client downstream hope as an individual in the world that there may be something different from that.
Yeah. And do you see that becoming available with that warm handoff that we have now for opioids, having a warm handoff for people who have a stimulant use disorder?
I think that we've done a bad job with referrals overall. We've had a tendency to give people a piece of paper and say, call this program, and then they disappear into the ether, and we never know what happens with them. I think with the opioid, with the increase in availability of treatments for opioid use disorder, we've seen more case management and networking assistance within the context of healthcare settings to help link people to behavioral health care in a meaningful way. And that really does give me hope. As more and more programs come on board as well in each of the counties that are participating, I think it's incumbent on those programs to reach out to healthcare, but also on the healthcare providers to know where those programs exist. And we can provide you with the website for the California Contingency Management Project. And on that website is a list of currently active sites that are enrolling patients in each of the counties that are participating. And that site is updated at least once a week. And so as we add new programs, they're almost in real time, they're added to that site so that providers across the state can know that there's the availability of these services to it.
I don't know if you've heard of the Bridge program that connects people from the emergency department. Each of these emergency departments, throughout the state have a substance use navigator and takes people who have an opioid disorder and, in real time connects them to treatment. I think that would be, I think that's the vision, that they do it not just for one drug, they could do it for any drug.
That's exactly right. If they're there, they should be connecting them to services regardless of what substance that they're using.
Yeah. And let me ask you about, in your pilot, are your patients just have a methamphetamine use disorder, or could they have fentanyl use disorder, cannabis use disorder, other drugs that they're using?
Yeah. We are only testing for the purposes of the reinforcers for stimulants. If they test negative for stimulants, they get the reinforcer, even if they're using other substances. So if they use alcohol, they use cannabis, they use opioids, they use any other substances. We want to know about that because clinically that's really important. And we want to make sure that we refer them for other services, for interventions for those substances that have become problematic for them as well. But in contingency management, the research says that if we try to focus on all of those things and make sure they're negative for everything, we get no results. But if we focus on one thing, not only do we get results on that thing, in this case, stimulants, but it also has a positive impact on the other problem areas that they have as well. So we see a reduction in other drug use in the research as a result of the focus on stimulants through the contingency management program.
So do you have people who are on buprenorphine also in your program?
Yes, we do. In fact, one of our sites currently, and we have a couple of others that I think will be coming on board soon, are opioid treatment programs where they're providing methadone or buprenorphine specifically to an opioid-using population. Opioid users often use stimulants in conjunction with their other substances, and so they're doing this program in the context of those sites as well.
Yeah, that's a great thing. By the way, the fact that you said that contingency management helps with other drugs, the reverse is also true. I've seen patients who take buprenorphine for their fentanyl, and that helps somehow their stimulant use disorder as well.
Mm-hmm. Mm-hmm.
All right. So I want to. You said it's very stimulant disorder is very tough, and there's no FDA approved medications now to treat methamphetamine use disorder. There is a drug that will soon be on the market, hopefully. It's a phase 2 clinical trials called CS1103. It doesn't have a cool name yet. And it's a sequestrant. So it completely absorbs methamphetamine. It's kind of like a Pac-Man shape, and it takes that methamphetamine out, deactivates it within minutes, and you pee it out. So like the thought of using this medication in the emergency department would be somebody comes in, with acute psychosis or agitation or acute reaction for methamphetamine, give them CS1103 and now they got their brain back. They didn't solve their addiction, but their acute agitation is done. And as you mentioned, it takes maybe 3 days to detox from meth. It takes a while. Mm-hmm. I'm wondering how you see like this potential medication being used in the settings you see? Like, would you, like, I'm thinking before you even start your detox, you can like get this out of your system and then at least start fresh with a clear brain. What do you think?
I don't know enough about the medicine to comment on it, frankly. It sounds very exciting, but I'm a science guy. And so what I want to do is I want to see the numbers, and I want to know kind of what exactly is happening and which population or subpopulation is it actually working for. We are very hopeful, and this sounds like an interesting and very promising approach to a medicine. We've been working, both our group at UCLA and researchers around the world have been working for decades to try to find a medicine that works for methamphetamine in the ways that you're talking about. I think at last look, there were nearly 40 compounds that have been tried that should have worked, according to all the theories, maybe showed small results with some subsegments of the population, and were either not replicable or turned out it didn't work at all. So I am hopeful that we will have a medicine, and maybe this is the one that will come to the market that will be able to help us with this problem. And as soon as we do, I will understand the neurochemistry of that medicine, and I will promote it in every possible way that we can for the populations that it works for. Because I think the answers to all of our problems are complex and multifaceted, and our interventions need to be complex and multifaceted. So right now for methamphetamine, we really only have a behavioral intervention, a purely behavioral intervention, that is the most effective tool that we have. With opioids, we have a medicine with the addition of behavioral interventions on top of that. And so the question then becomes, what's the optimal combination and timing when a new medicine comes on board, so that we can partner those together and give that individual who's sitting in front of us the best chance for life and the best chance for a successful.
That's great. Well, perhaps one of the clinics and sites that you're associated with would partner for those type of studies. Again, with a new medication, will happen. But it's different. It doesn't treat addiction. It's not a replacement kind of medication as buprenorphine is. It's a sequestrant. We're getting it out of your system. It works for fentanyl too. So if it's in that acute phase, when you're high, it takes that out of your body, so now you can kind of start fresh.
It sounds very, very exciting. And I will say that we've had 4 or 5 really exciting drugs on the market where the marketing got way ahead of the science. And when the science finally came out, they didn't work.
I like your skepticism. I
am hopeful for that science, and I wait for the day that that's released so that I can read it and review it and make sure that I believe that it works as well as it does, and that it moves on to FDA approval, and that we really get a compound that's indicated for this particular purpose. And on that day, we will all celebrate amazingly.
Right. Well, there's no magic bullet for anything. Being around in medicine for a long time, you're right. I've seen a lot of medications that tout to be the next, magic spell for things, but nothing is, including cannabis, which is marketed out to help everything from AIDS to cancer to everything, billboards everywhere. And yet, I'm sure your clinicians and I see cannabis use disorder on a daily basis. I see cannabis poisoning every single day in various forms, from psychosis to cannabis hyperemesis syndrome to drug interactions to heart effects. What are your clinics, and what training is out there? I see a huge gap actually for this as well, for people who have cannabis use disorder. We have, if I had to do, my one quick suggestion would be, we have tobacco cessation programs. We don't have cannabis cessation programs, even for people who want to quit and they can't.
Yeah.
Or, what do you think?
There are programs doing really good work with cannabis, and what we've demonstrated is that what the research shows is that many of the same behavioral interventions, cognitive behavioral therapy, motivational interviewing, et cetera, work really well with cannabis. Motivating people into treatment is often the biggest obstacle associated with that. The other thing is, I think that we need more public education about the dangers of cannabis. The industry has done a really good job of saying, how it's the cure-all for everything, but the research is actually really limited, and there are only a few conditions that have been really demonstrated to be benefited through the use of cannabis, and lots of things that maybe, and most things probably not benefited through the use of cannabis. And I think that we need to come to a place like we do with opioids, which is we need them for certain things. If you cut your hand off, and having opioids around is probably a really good thing to ease that pain and help the person through that crisis, but that there's real danger associated with its use. And I think the more we can educate the public about the reality, I'm not a scare tactics guy. I'm like, this is what we know it's good for. This is the dangers that we need to watch
Tom,
out
can I
for.
disagree with you here also? It's not like opioids, because opioids are FDA approved. They went through that scrutiny. And so we know the dangers and the risks, like what's written on an FDA label. And, and there's dangers with any medications. And we kind of went too far with overprescribing opioids with that marketing. It's good for everything. And now I'm back to a balance. Like, you need surgery, you broke something, you have cancer. That's what it's for. The difference with cannabis is it's not FDA approved.
Well, it's not FDA approved because it's not researchable for an FDA approved medicine because of the way that it's scheduled. And I think that if we were to, and there's movement afoot to reschedule it so that it is researchable, there is really robust research that for a few conditions, very few conditions, that cannabis might be helpful and probably could lead to FDA approval for those specific indications.
But Tom, I had several podcasts with people who do that research. There are 2 FDA approved, several actually, FDA approved. Marijuana is a plant with 500 different chemicals, including carcinogens. That's very different.
Which is why the delivery method is really critical, and smoking anything is really a bad idea, and dosing through smoking is impossible, and vaping is problematic. So there are lots of things that we don't understand about cannabis. I think putting good information about all of those things, the dangers of smoking, the dangers of vaping, the delivery method, and the difference in dosing, that cannabis is not cannabis is not cannabis. The cannabis that I wasn't smoking when I was a teenager is not the same cannabis that's on the street today. And even that cannabis comes in forms that are from 15 to 98% pure THC. And we have no idea what those higher THC amounts do along the way. It's a dangerous compound, and we need to be really aware of it. I think the first step is beginning to get real education into the communities about the product, and really helping people see that while cannabis may be useful for some things, it also is counterproductive probably for more things than it is useful for some things. I don't think we can take a draconian sort of prohibition kind of approach. That horse has already left the barn. So now the question is, given the state of the situation that we're in, how do we reduce harm as much as possible?
Right. I agree with you that knowledge is important. I just want to push back also on the scheduling. We do have a lot of research and currently going on and developing medications for cannabis. I'm for FDA approved cannabis based medications, and there's a bunch of development out. That's very different than you going to a pot shop and saying this.
We don't disagree at all.
Okay.
Yeah.
And we actually tried to pass some laws in California for that education. 2 years ago, we tried labeling on the product that would say warning, just like you have warning for alcohol and tobacco. The state shot that down. Last year, we tried to protect children. There's the number one drug that children come to the emergency department for is cannabis. In the form of like these candies that's attractive to little children. And these are kids under the age of 5. They don't have an addiction. They're just getting into mommy's purse. That got shut down. So I want to run an idea by you, see if you support this as well. So this year, actually, after recording this podcast, I'm going to have a conference call and with the Pharmacy Association to see if they'd support us in labels on prescriptions. So again, this is not people who have an addiction. These are people who pick up their Plavix medications or their blood pressure medications, and there'll be a warning label saying, warning with cannabis. Just like you have a warning, don't use with alcohol, take with milk. It's just education. Don't take with grapefruit juice. So there are several medications that can cause severe interactions if you use them with cannabis products. So what do you think of that idea?
I think that the more education we can put out in the more diverse ways that is real and balanced and accurate, the better for everybody involved. And so again, without knowing the specifics of what you're proposing, I don't want to comment on that specifically, but I think having avenues to get education out about potentially dangerous drug-drug interactions doesn't seem like it could be a bad thing.
Yeah. We actually did the research on that. We sent out 10,000 info cards to people who were picking up prescriptions and asked them, hey, would you want this information? And over 90% of people wanted that information, and pharmacists thought that was important too.
That's great.
All right. So, Tom, tell us what's out there for you and your institute and teaching and PTTC. Tell us what's on the horizon for 2024.
We're continuing to fight the good fight. We want everyone to know everything they can about effective treatments for substance use disorders. This contingency management project is one of many things that we do, but our group at UCLA ISAP does over 300 trainings a year, all related to addiction and addiction treatment. So there are a number of resources that are available to people, both live virtual courses, face-to-face courses, as well as self-paced courses, all of which are available for continuing education. And my hope, Dr. Lev, is that you can put a few websites on your podcast that I can send to you that people can link to for resources, both for the CM project, but also if they're interested in receiving training or technical assistance on other aspects of substance use across the spectrum. We can probably help with that as well.
Yeah, and tell us what are some of those things we can put in a plug for your programs.
Well, the online course catalog that we have, the self-paced course catalog, I think is really amazing. We have over 80 courses right now. They're primarily experts who've been recorded. We've broken it up into small segments to make it palatable, and you can watch the recordings and take a small quiz at the end of it and get continuing education for it and learn kind of on your own time, available for that. Over 80 courses, all free of charge, including continuing education. We also do training on motivational interviewing. We do training on contingency management. We do training on cognitive behavioral therapy, as well as specific trainings on each of the substances that are out there. So if you want to know more about methamphetamine, as I said, I could talk about it for 2 hours. We have a full day curriculum that's on nothing but methamphetamine and its impact and its treatment. So lots of resources available, and most of the services that we provide are free of charge to the public through funding through the either local, state, or federal grants and contracts.
And this is for clinicians or public or anybody?
Our primary target audience is clinicians, but we do have services that are available to the general public as well. So if you have a need, contact us and we'll help you somehow, either by referring you to the right resource or providing that service ourselves.
That's great. All right. Well, thank you so much. That was very interesting. Lots of success and many good courses and a lot of education. Thank you, Tom. I wish you a lot more success, and I love your passion and intelligence and advocacy and all that.
Awesome. Thank you very much. I enjoyed the time today, and I appreciate the opportunity.
Thank you for listening to High Truths on Drugs and Addiction, where you learn from experts from around the globe and around all aspects of drugs and addiction. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to FAF, Families Against Fentanyl. Visit familiesagainstfentanyl.org to learn more. High Truths producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more High Truths.